This is Outbreak News This Week, brought to you by the Global Dispatch Incorporated. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Harriman.
Well, good evening, Tampa Bay. My name's Robert Harriman, and this is Outbreak News This Week, your source for all the news about worms and germs. And I want to encourage you to check out the website, OutbreakNewsToday.com, OutbreakNewsToday.com. A lot of interesting news on there during the past several days. And on Thursday, the CDC published a study in the journal Clinical Infectious Diseases and reported that vaccination with Tdap, it's a vaccine, TDAP, it's for whooping cough or pertussis, during the third trimester of pregnancy prevented more than 78% of cases of pertussis in babies younger than 2 months. However, the study found that only 49% of pregnant women who delivered between the fall of 2015 and the spring of 2016 received the vaccine. So based on these numbers, the CDC recommends women get the Tdap during each pregnancy to provide critical short-term protection to babies when they're really at the most risk for a life-threatening illness. And what the study looked at, it looked at data from 2011 to 2014 on babies younger than 2 months from 6 different states. And it found that the mothers whose babies had whooping cough were less likely to have received the Tdap during pregnancy. The study reported that in addition to being 78% effective at preventing whooping cough, Tdap vaccination during the third trimester was 90% effective at preventing serious cases of whooping cough that required hospitalization in these young babies. Director of the CDC's National Center for Immunization and Respiratory Diseases, Dr. Nancy Maisonier, said women have such a great opportunity to help protect their babies before they enter the world by getting the Tdap vaccine while pregnant. This study highlights how babies can benefit when their mothers get the vaccine and reinforces the CDC's recommendation for women to get Tdap vaccine in the third trimester of each pregnancy. And whooping cough is very, very serious, particularly in the young babies. In this study, 65% of babies younger than 2 months who got whooping cough needed treatment in a hospital. Babies younger than 1 year are at the highest risk for severe complications or death. Typically between 5 and 15 babies die from whooping cough each year in the United States. And most of these deaths are in those that are too young to be protected by getting their own vaccines. Babies do not get vaccinated to start building their own protection against whooping cough until they are 2 months old. So I encourage you to check out that study. It's published on the OutbreakNewsToday.com, OutbreakNewsToday.com. Some other interesting news. We've been keeping an eye on this for months now, and that's the rat lungworm situation in Hawaii. And another case has been identified, the 17th of the year, which is a record. And sadly, the case is actually in a infant from Big Island, Hawaii Island. And apparently they suspect the child accidentally consumed a slug or a snail. Aaron Ueno, Hawaii Island District Health Officer, said this is an extremely unfortunate incident with the infant currently hospitalized and receiving care. So, as far as children, the Hawaii Health Department is recommending taking these precautions to watch the infants, toddlers, and other children while they're outside playing and make sure they're not picking up slugs and snails and other things that might carry this very serious parasite, the rat lungworm, and help children to properly wash their hands after playing with running water and soap. And if you're not familiar with rat lungworm disease, it's caused by a parasite called Angiostrongylus catarrhensis. And the infection in the person occurs almost exclusively accidentally when they consume raw or undercooked infected slugs, snails, land crabs, frogs, or shrimp. And the symptoms can be severe, including headaches and neck stiffness, and a lot of neurological problems. And there are cases of fatalities. And it causes something called eosinophilic meningitis. So I encourage you to check out that story on OutbreakNewsToday.com, OutbreakNewsToday.com. Now, methicillin-resistant Staphylococcus aureus, or MRSA, is a bacteria that is resistant to many common antibiotics. And it can cause a whole slew of different problems, ranging from skin infections and sepsis to pneumonia and bloodstream infections. Now, Monday is World MRSA Day, a day to raise awareness of MRSA around the globe and to activate survivors, communities, governments, healthcare officials, and personnel to join together to stop the spread of this preventable disease. Joining me now to discuss MRSA, or what we like to say in the lab, MRSA, World MRSA Day, and to tell her personal story is founder of the MRSA Survivors Network, Jeanine Thomas. Hi, Jeanine.
Hi.
Welcome to the show, and I appreciate you talking to me today.
Well, thank you for having me.
Okay, let's start off with a little overview of MRSA and give the audience a snapshot of this bacteria and how common is it?
It started, they first saw it in the UK in 1960. And so they first saw it under the microscope. Patricia Jevons, she was a microbiologist. And then it was released into the world. And so it is predominantly 85% of people who get infections are in healthcare facilities. But we see that it is spreading into the community. More people in the community are getting it. So, and the strains, the community-acquired and the hospital-acquired strains are commingling.
Right.
So this is what's going on. It's an ongoing epidemic in the U.S. and globally.
Now, one of the big problems with this is it's resistant to antibiotics. Can you discuss what is methicillin and why is resistance to this antibiotic so significant?
Methicillin isn't used anymore, so it's oxacillin, but they tried to change it to, instead of MRSA, to ORSA, but it never caught on.
Right.
So it is methicillin-resistant Staphylococcus aureus, or MRSA. And what it is, it's a Staph aureus that is antibiotic resistant, and there's only a few antibiotics that work really well for it to be treated.
And so if they're resistant to the methicillin, essentially the common antibiotics used for Staph aureus, what we call beta-lactams, cannot be used. And that's the way it is, yeah. Now, as you kind of mentioned, years ago, this was thought of almost exclusively as an infection associated with hospital stays, but that's not the case anymore, is it?
No, it has escaped the hospitals, and there are strains now, community-acquired strains, and they are found in daycare centers, fitness centers, gyms, everywhere, the grocery store. I mean, it's just out there on surfaces throughout the community.
Mm-hmm. So, Jeanine, who's at risk for MRSA infection, and how does one contract it?
Everybody's at risk, from newborns to elderly, and our pets also, and farm animals, zoo animals. Everybody is at risk, and it's contracted by contact, so that you contact something that has MRSA, MRSA on a surface.
Okay, so it can be from a surface. It can be skin to skin.
Right.
Yeah.
Fabric, inanimate objects. It lives. They say at least for 4 or 6 weeks, could be even longer. They don't know for sure that these cells, these spores, can be on surfaces. And if you go along and you have a microcut or touch your eyes, your nose, then you can become colonized. And 99% of the people who are colonized don't get an infection. We live with this. 30% of us live with staph on our body, and our microbiome is fine with this. But some people do get infections, and they can be very virulent very quickly also. So that is the risk, that people take with MRSA.
Right. Okay, let's get a word from our special guest at Global Lyme Diagnostics. Now, for many years, we've been waiting for a Lyme disease test that actually works. After decades of research by Dr. Richard Marconi, a professor at the Medical Center at Virginia Commonwealth University, a breakthrough test has been developed. The GLD test, recently launched by Global Lyme Diagnostics, is based on Dr. Marconi's science. For more information, visit glymedx.com. That's glymedx.com, or email them at info@glymedx.com. Well, Jeanine, I was really excited to get you on because I wanted to hear your story. Now, you're a survivor of severe MRSA infection.
Yes.
Would you mind telling the audience and myself your story?
Sure. I was infected during ankle surgery. I broke my ankle, and I had to have 2 screws and a plate put in. And I was infected during surgery with MRSA. It went right into my bone marrow. It went into my broken bones. So something was contaminated in the OR. And I was in the hospital for a few days and came home, and then my leg just swelled up. I didn't feel a fever. I just felt very nauseous. I paged my surgeon. He says, you either have an infection or your cast is too tight. Well, it was both. Mm-hmm. I went into the ER, and my incisions were black and oozing a large amount of pus, and it was disgusting. And they admitted me right away. I couldn't have surgery because I'd eaten that day. And I don't remember the 3-4 days. I don't remember because I was so sick. So it had gone into my bloodstream. And I was not put on vancomycin, which was the only drug back then for it in 2000. And so I was on a broad-spectrum antibiotic, and so I went into septic shock and multiple organ failure the 4th night in the middle of the night with 105 temperature. And I had the out-of-body experience. It was very dramatic. But I finally got on vancomycin, and I are still here today, but I had to have 7 more surgeries to save my leg. And after I got out of the hospital, after a month, 2 weeks later, I woke up with diarrhea and vomiting, and I went to the ER, and I had contracted C. difficile. It's another deadly pathogen, so I had to deal with that. And I needed a skin, bone, and muscle graft, but I could not have it because of the infection, so my leg had to heal itself. It took 6 months to heal, and it was, never as strong as it would have been if I'd had those muscle grafts and things like that. So it was a long recovery. And a year later, then I had the hardware taken out because my infectious disease doctor said that they knew the bacteria was underneath, and I wanted to lessen my chances of having a recurring infection. But then MRSA, because it was in my body, it moved into my sinuses. And I was sick for 3.5 more years, off and on, with infections. And it was very scary, very long time. Spent completely 17 months in bed. It was very debilitating. And nobody knew what to do for me. There was just not the antibiotics they have now. And they just hadn't seen it move like that in the body. So it was a really long, painful ordeal.
So how are you today?
I'm good. I have not had another MRSA infection, but the long-term use of antibiotics I had for so many years has weakened my immune system. So it's never the same. So I get attacked by bacteria and viruses, especially viruses in the wintertime. So this is the long-term effects of taking a lot of antibiotics, that your immune system is severely weakened.
Okay, well, this horrible story that you just gave us, other than the fact that you are a survivor, has prompted you to become an advocate and an educator on MRSA infections and to launch the MRSA or the MRSA Survivors Network. Jeanine, can you talk about what your organization does?
I started my organization in 2003. I started looking at in 2002, even while I was still sick, of what I could do because I wanted to raise the alarm because I knew 7 other people who had infections just within my friends and family, because I'm in Chicago and we were one of the cities, besides Baltimore, that was ground zero in the U.S. for MRSA. So I said, nobody's talking about this. How can this be happening? And it was a very isolating experience for many because you go through anxiety, depression, anger, all of these things, and there was not a support group. So that's one of the first reasons why I started my organization, was to help other survivors, because it's very isolating. You're at home sick, and you're infectious, and so that is the reason I started, was to help others and to raise awareness and educate others.
Mm-hmm. Now, Monday is World MRSA Day, and what is the goal set out for this Monday?
Monday is an annual awareness campaign, and October is World MRSA Awareness Month. It is to raise awareness to MRSA, and it's about prevention, because in hospitals, this is a preventable disease. It's a medical error. It's a never event. This should never happen. It's because there's things that are contaminated in the hospital. And so this can be prevented. And people just don't know what they need to do before they go into a hospital. And this is what our organization does, is to raise awareness and educate people. And we find the state and county health departments are not putting the message out there. And so this is what we do, because this is a global epidemic. And I work with the World Health Organization since 2008. And they know that we're at the end of antibiotics. If we continually to use antibiotics and don't get these infections under control, they're going to continue, these superbugs are going to continue to mutate. And we're going to not have any antibiotics for simple surgeries like it was in the 1800s. So it's really important that prevention saves lives, that we stop these infections in healthcare facilities.
Now, Jeanine, if someone wants to learn more about MRSA, the MRSA Survivors Network, or how they can get involved, where can they go?
They can go to our website. We have a new website up for the last couple of weeks. It's MRSAsurvivors.org. We have a crisis hotline, and people email us all the time. We're the persons to go to get information that you can't find from the CDC, the health departments, or whatever. And because we listen to stories for so many years, and that we know, what people need to do and what the resources there are. And so we're really there to help the public.
Right, and I checked it out. It's a very good website, and I encourage people with an interest to check it out. And if you want to get involved, you want to donate, whatever you want to do to help out the MRSA Survivors Network. Again, the website is MRSAsurvivors.org, and I will post that when I post the audio on the website.
Wonderful.
Yeah.
Thank you.
And I want to thank you, Jeanine, for sharing your story, and good luck on Monday, World MRSA Day.
Thanks. And our kickoff event is on Saturday.
Oh, okay, great.
We have a big kickoff event in Chicago, and that kicks off the monthly promotions that we have for this annual event.
All right. Well, I hope to have you on again and talk about this topic. And
sure, I can talk about C. diff, sepsis, antibiotic resistance. Like I said, I'm with the World Health Organization, Brookings Institution, the FDA. I've been with them since 2008. So I'm with a lot of different organizations, and I've raised awareness and educated them.
Excellent. Well, thank you, Jeanine Thomas. I appreciate your time.
All right. Thank you.
All right. Bye-bye.
Bye-bye.
Okay. And again, the website, if you're interested, MRSA is very common, so there might be a lot of interest out there. It's MRSAsurvivors.org. That's MRSA Survivors.org. And like I said, when I post the audio of this interview, I will have a link to that in the article, so you can just click it on and go there and check out what Jeanine and the others are doing at the MRSA Survivors Network. Well, in addition to World MRSA Day, of course, this show airs on Sunday nights, but we do record it on Thursdays, and today is September 28th, and today is World Rabies Day. That happens every September 28th, and it's, again, for putting out information about this absolutely lethal virus, and very, very preventable, though. And if you go to the website, my website, outbreaknewstoday.com, I put up a blog post, Rabies, What You Need to Know, and it just goes over the ABCs of, symptoms, what an infected animal appears like, and what you should do if you do get bit, and et cetera, et cetera. And I also want to encourage you to check out the very good interview that I did with Pamela Wilson. I don't know, it was about a year or two ago about rabies. It's about more than a half hour long, but I encourage you to check that out. I entitled that Everything You Wanted to Know About Rabies. So you can find that on the website, outbreaknewstoday.com. Okay. Getting close to the break, I want to go over some good news coming out of the Americas. And the World Health Organization announced this past week that the region of the Americas, that's Latin America, Central America, the Caribbean, and North America, has eliminated maternal and neonatal tetanus. This is a disease that used to be responsible for the deaths of more than 10,000 newborns every year in the Americas. Maternal and neonatal tetanus is the sixth vaccine-preventable disease to be eliminated from the Americas, following the regional eradication of smallpox in 1971, polio in 1994, rubella and congenital rubella syndrome in 2015, and measles last year. The director of the Pan American Health Organization said, "The elimination of maternal and neonatal tetanus is proof again that vaccines work, save lives of countless mothers and babies. Let us continue to protect the people of our region by investing in strong national immunization programs that are capable of vaccinating all individuals and quickly identifying vaccine-preventable diseases." Now, unlike other vaccine-preventable diseases, maternal and neonatal tetanus is considered eliminated when there is an annual rate of less than one case of neonatal tetanus per 1,000 live births in a district level. And this is because tetanus can't be fully eradicated because the bacteria that causes the disease, Clostridium tetani, exists throughout the environment in soil and feces in many different animals. So, some pretty good news coming from the World Health Organization on the elimination of maternal and neonatal tetanus, something that killed thousands of children not too long ago. Okay, I'm getting very short on time. I want to encourage you to check out the website, outbreaknewstoday.com, outbreaknewstoday.com. I also have a Facebook page that's thriving and getting close to 64,000 likes or followers. And you can check that out at Infectious Disease News. That's on Facebook. And the podcast, Outbreak News Interviews. And you can find that on iTunes and Stitcher Radio. And if you go through some of the headlines, we see some information on measles in the Americas. We have some studies concerning the risk that older siblings pose for serious flu for their babies and toddlers. So, and many, many other stories. So, okay, after the break, we're going to talk about a couple different topics, hepatitis A, and we're going to talk about Medicare for all. So I'll see you after the break.
Welcome back to Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the program. Well, I have to say that 2017 has been a very, very unusual year for hepatitis A. I mean, we're seeing some very large outbreaks in different parts of the country. Up in the Detroit, Michigan area, it's well over 300 cases in their outbreak and 14 deaths. You know, I know when you think of hepatitis A, you don't typically think of deaths, but yeah, it's happening. And in California, San Diego is well over 400 cases and 17 deaths. And there's an outbreak going on in Los Angeles County now, too. In New York City, they reported about 46 cases, and the vast majority of that are in men who have sex with men. So we have a lot of hepatitis A issues going on in the United States. And a couple months ago, I did a podcast interview with infectious disease physician Dr. Amesh Adalja about hepatitis A, and I wanted to go ahead. I thought it'd be a good time to share that with you right here on the show. So let's take a listen. Joining me now to discuss hepatitis A is Amesh Adalja, MD. Dr. Adalja is a senior associate with the Johns Hopkins Center for Health Security. Dr. Adalja, welcome to the show, sir.
Thanks for having me.
Okay, well, hepatitis A is a highly infectious viral disease. However, there are some significant differences between this and the also common ones, hepatitis B and C. What are these differences?
Well, we have a whole basically alphabet soup of hepatitis viruses. There's hepatitis A, B, C, D, and E, actually. So hepatitis A is one that's primarily spread through what we say is the fecal-oral route. So you're basically getting it through something that's been contaminated by fecal material that has the virus in it, whereas hepatitis B and C are more bloodborne. For example, hepatitis B is something that people got with blood transfusions. It's also something that can be spread sexually. Hepatitis C is almost exclusively bloodborne, where we see such a major epidemic with the injection drug users. So they are all called hepatitis viruses, but they're all in different families, and they're spread differently. The thing to know about hepatitis A, it's the one that's spread through contaminated food and water.
Okay. And how common is this in the U.S.?
It was something that was very common. It was something that children got routinely, but it has become exceedingly rare because of the success of the hepatitis A vaccine. Back here, I don't know if you remember, in Pittsburgh around 2003, in the Pittsburgh area, we had the largest outbreak in the United States at a Mexican restaurant chain, which is now gone, called Chi-Chi's, where there was a lot of cases. So it was something that did happen sporadically, but the vaccine uptake has become so high that we're starting to see much less cases.
Right. What are the symptoms of hepatitis A, and how long do they last?
So the symptoms usually include fever, chills, fatigue. People will hepatitis virus. People will start to get basically jaundice, so they may have yellow skin, the whites of their eyes may be yellow, their urine may be dark, their stool may become clay colored. They can have nausea, vomiting, abdominal pain. And the symptoms usually last, up to about less than 2 months usually. So it isn't something that's it is an acute illness, but it sometimes can have protracted symptoms. The interesting thing is, when kids get it, most of them are probably not even going to have any symptoms from it, but yet they're contagious.
And even if you're not showing symptoms, you're still contagious, right?
Right. Yeah, you can still shed the virus in your stool.
Sure. Okay. For many years, we have been waiting for a Lyme disease test that actually works. After decades of research by Dr. Richard Marconi, a professor at the Medical Center at Virginia Commonwealth University, a breakthrough test has been developed. The GLD test, recently launched by Global Lyme Diagnostics, is based on Dr. Marconi's science. For more information, visit glymedx.com. That's glymedx.com, or email them at info@glymedx.com. Okay, now in southeast Michigan, there's an outbreak. They've had about 190 cases and 10 deaths. And they report no common source of the outbreak, like contaminated food or water. And they say the transmission appears to be person to person through illicit drug use, sexual activity, and close contact among household members. Then if we look at the other side of the country in San Diego, the outbreak's been a little bit larger, about 228, and a good bulk of them have been hospitalized. And there's been 5 fatalities. And health officials are essentially saying that the homeless people and people using illicit drugs account for about 70% of the illnesses. And just over 1 in 5 also have hepatitis C, by the way. Now, this outbreak in Europe is pretty massive, and there's hundreds of cases, and it's mostly among unvaccinated men who had sex with men, or what we call MSM. Dr. Adalja, can you talk about these risk factors and others?
Yeah, sure. So hepatitis A does have kind of a group of risk factors that you often see common to cases. And the first, if you're talking about the United States, one of the things you might see is travel. So somebody may go to an area of the world where hepatitis A is more common, and then they may ingest contaminated food or water that has it. We also see men who have sex with men who may have fecal oral contact that could cause the virus to transmit. So that's another high risk group. Injection drug users can also be a risk group. They can share needles, and the virus can be, although it's mostly a fecal oral transmission. If it's in the bloodstream and you're injecting directly in a contaminated needle, that's another way that you could get it. People who are around certain animals that may have the disease as well. So there's kind of a general conglomeration of risk factors that you can often find in any outbreak setting.
Any significance to the point they made in San Diego that about 20% of them also have hepatitis C?
It is important because when you have hepatitis C and then you get a super infection with hepatitis A or vice versa, or any other hepatitis virus, hepatitis B or C, and then you get a super infection with hepatitis A, that can lead to really fulminant disease where you can have severe symptoms and may die because of the combination of the two viruses basically acting synergistically to destroy your liver.
Yeah, and this virus is the viral disease is typically considered a mild disease, but we do see quite a few deaths between Detroit and San Diego. Does that seem high to you?
It's hard to say exactly because we know that while most cases are mild, we don't know that much about the case histories of these patients. How many of them have hepatitis C? How many of them have hepatitis B? How many of them have alcoholic liver disease? How many of them have diabetes? How many of them have how old are they? All of these types of factors can play into how well they might tolerate a hepatitis A infection. Mm-hmm. So obviously in uncomplicated cases, you may have a couple months of really bad symptoms, but you don't die, but we don't know exactly what else is going on, what the comorbidities are in these patients. So that may explain the mortality numbers that we're seeing. Sure.
Now, because this is a virus, there's no specific treatment. However, there is a vaccine to prevent it. I think it was launched in 1995. Dr. Adalja, what can you tell us about the vaccine?
It's a very effective vaccine, and now it's become something that's part of the routine childhood immunization in the United States. So all children are now, if they're following the vaccine guidance as they should be, they would be getting vaccinated against hepatitis A. And it's a 2-dose regimen. There's even a combination vaccine now that has hepatitis B and A in it at the same time. So this is something that really has revolutionized the rates of hepatitis A in the United States and made it something that has become very, very rare.
And this is a vaccine that, of course, you would recommend for travelers going to Mexico and countries like that.
Yeah, it's important if you're traveling to any country to look at the CDC travel website and see which vaccines are recommended. Although some people may have gotten hepatitis A as a child and then they don't necessarily they may not need the vaccine, but there are regimens that you should take if you are going to an area and you're not immune. And not just the vaccine. Some people, if they're going really quick, have to get the immune globulin, which is the antibody to give them fast protection. Mm-hmm. in those areas. I was somebody who got the hepatitis A vaccine as a traveler when I was about 22.
Okay. Now, though we're seeing these outbreaks in San Diego and the Detroit area, overall, has the introduction of the vaccine in the U.S. Reduced the number of cases in this country and in other countries?
Yes, significantly. Anywhere you see this vaccine being used, you see a real decrement in the number of cases, and we've seen hepatitis A cases fall substantially. If you look even at the CDC graphs, it basically drops off substantially as soon as the vaccine reaches high enough levels. So it is something that has the numbers are there's probably some underreporting, but the numbers are not very high anymore in the United States. They estimate about 2,500 cases. Based on what they think is being underreported in the number of reported cases.
Yeah. Is there anything else you'd like to add?
I think it's important that people realize that hepatitis A is a contagious infectious disease, and it's not something to worry about so long as you've been vaccinated. But in those adults who may not have been infected as children, it is something that you have to think about your risk factors for. And injection drug use is one that can spread it, as well as contaminated food. But it is something, hopefully, that they'll get a handle on, because we have an effective vaccine and we have the ability to actually intervene to stop these outbreaks in the United States.
Excellent. Okay. Thank you again, Dr. Amesh Adalja, for your time and expertise. I appreciate it.
Thanks for having me.
All right. Well, I want to do another interview. I actually have a second podcast called The Robert Harriman Show, and if you're not aware, I have another website. It's called theglobaldispatch.com, and that's where this podcast is housed at. And it's not so much medical, it's more society and culture type topics. And I recently spoke to CATO Institute Senior Fellow Michael Tanner about the recently introduced legislation known as Medicare for All. And I want to go ahead and play that interview for you and get Dr. Tanner's thoughts. So let's take a listen. Now, while much attention has been on the legislation proposed by Senators Bill Cassidy and Lindsey Graham, better known as the Graham-Cassidy bill, and yesterday's no vote on it, what some people may not be aware of is 2 weeks ago, Vermont Senator Bernie Sanders and 16 of his colleagues introduced legislation to guarantee health care to every American by expanding and improving Medicare, better known as Medicare for All, or in other words, a single-payer health care system or socialized medicine. To take a closer look at Medicare for All is CATO Institute Senior Fellow Michael Tanner. Michael, welcome to the show, sir.
Well, thank you. It's a pleasure to be with you.
Excellent. Now, I know you're familiar with the Sanders et al. Bill. Can you give the audience a summary of what they're proposing?
Well, essentially, this would be a single-payer system, a lot like Medicare is today, but much more generous. Basically, you would be able to go to any doctor that accepted payment, and the doctor would then submit the bill to the government, which would pay them. You would, in turn, of course, pay much higher taxes, but you wouldn't have any co-payments, deductibles, insurance premiums, and so on.
So do we know any specifics, like how much this government program would cost and how they would plan to pay for it all?
Well, we don't really know because this has not received scoring from the Congressional Budget Office. However, outside experts, including those at the Urban Institute and folks from CNN, have looked at it, and they've suggested that it's anywhere from $1.4 to $3 trillion per year.
Wow.
So that would be somewhere between $14 and $30 trillion over a 10-year period in additional government spending.
So, but as far as taxing authority, what's Sanders' plan, to go after the rich people again?
Well, that's always his favorite plan. He actually did not include any pay for in the bill, so there's no actual way to pay for it included in the legislation. He did, however, from his office, offer a number of suggestions, including a roughly 10 to 15% increase in the payroll tax, a 4% income tax on hike on all Americans, in addition to the payroll tax hike, plus additional taxes on the rich and corporations as well. So essentially, we'd all be paying a lot more under his plan.
Now, the benefits that are proposed are pretty comprehensive, from emergency services to primary care, prescription drugs, mental health, everything to audiology. Now, how does this socialized medicine program compare to similar programs in Europe and Canada?
Well, this is much more generous than any program that we're liable to find anywhere else in the world. For example, the Canadian system, which Senator Sanders talks about a lot, does not cover the full cost of prescription drugs, but this would cover 100%. The Canadian system doesn't cover all the vision and dental care. This would cover 100% of vision and dental, and so on. This would cover more than, say, in UK. There would be less out-of-pocket costs than, say, in France or Australia. This would, by far, be the most generous healthcare plan in the world.
Now, anytime you have a free government program, or anything that's free for that matter, that really skews supply and demand. Would you like to comment on that?
Well, certainly if this is free, it's going to increase demand. People are going to be quicker to go to doctors, and that's sometimes a good thing, sometimes not. But more people are going to want to see doctors. But at the same time, the senator wants to impose price controls. In fact, he wants to squeeze some $6 trillion over 10 years out of the current system by reducing rates of reimbursements to doctors and hospitals. If you do that, you're going to drive doctors and hospitals out of business, or out of the system at least. And that means you're going to have lower supply. You get common sense that if you have increased demand and lower supply, you're going to have shortages. That's sort of economics 101.
Exactly, and it's as if we didn't learn anything from the Nixon years.
Well, price controls have worked. I think Ronald Reagan used to point out that they didn't work back in the Roman Empire, and they used the death penalty to enforce them.
And so one of the concerns you mentioned is there a concern for doctor shortages. I mean, did we see that in Massachusetts?
Well, we face doctor shortages as it is. We're about 150,000 doctors short of what it's going to take just to take care of the population we have now as we age. And this is certainly not going to do anything to encourage doctors to go into the system. You know, Medicare already under-reimburses doctors, which is why about a third of physicians are either not taking new patients or not taking Medicare patients at all. That's an increasing problem in the existing system. Imagine expanding that to everybody.
Now, just talking briefly about the current Medicare program for seniors, you hear most people say that this is really, really a popular program, and I believe it is. My mother's on it. However, there's a reason for its popularity, and it's not fiscal responsibility or sound economics, is it?
Well, no. In fact, Medicare is promising benefits and paying benefits that it really can't afford. According to the trustees of the system, Medicare is some $50 trillion in the red going forward. It means our kids and our grandkids, of course, are not going to be able to get the benefits that today's seniors do. On the other hand, it provides a lot of benefits for people who aren't really sick. It pays for your checkups. It pays for your routine care, pays for your prescription drugs. For a lot of people, this is a pretty good deal. Now, Medicare, if you get really sick, of course, doesn't cover you. That's why you end up in Medicaid if you're in a nursing home. And it's not a good deal for our kids and grandkids who are going to put the $50 trillion that we owe.
All right, just to get a snapshot, what chance does Medicare for All have in the United States of America today? And is this something that we're probably going to see in the future?
Well, today it has exactly zero chance. There is no possibility whatsoever that it is going to get 60 votes in the United States Senate with a Republican majority. If every Democrat was for it, it still wouldn't come close, and not all the Democrats are on board. But it is a harbinger of things to come. If we look at who is co-sponsoring this legislation, it is almost everyone who's seriously talked about as a potential 2020 presidential candidate. So you see Cory Booker on board, and Kamala Harris, and people like that who have signed on. You see a lot of the intellectuals within the Democratic Party and the activist base supporting this. The Democratic Party is being driven left as fast as the Republican Party is being driven right by their activist bases. This could be a very interesting campaign issue come 2020.
Okay. And finally, Graham Cassidy never got a vote yesterday. I'd just like to get your thoughts on Graham Cassidy, the pros and cons, and the future of it.
Well, on the con side, Graham Cassidy didn't repeal much of Obamacare. Basically, it left all the spending and all the taxes in place. It simply changed how that spending was done. It delivered it back to the states in the form of block grants and changed the formula for those states, taking some money away from the Democratic states, particularly California, New York, and Massachusetts, and shifting that money out to more rural states that tend to be represented by Republicans. It did, however, give governors a little more flexibility in use of that money. That probably would have been a good thing. So it really fell short of any sort of repeal of the Affordable Care Act. Improvements would have just been on the margin, but it probably would have made some improvements. It would have certainly have gotten rid of the individual and employer mandates, which, of course, are very unpopular.
So can something like Graham Cassidy ever get 60 votes?
I'm not sure Mom, Apple Pie, and the Flag could get 60 votes in this Congress right now.
Yeah.
Realistically, the problem is that health care is hard, as Donald Trump once said he discovered. What American people tend to want in terms of their health care is something that's almost impossible to deliver. They want all the health care they can get with a doctor of their choice and no wait, and they want it for free. I haven't yet figured out a bill that's going to do that.
Yeah, that's a utopia for sure. Well, thank you very much, Michael Tanner, for your thoughts, your time, and your expertise. I appreciate it.
Anytime. Always happy.
All right. Take care. All right. Well, I hope you enjoyed that interview. You may not agree with it, but it is out there, and you can check out the Robert Harriman Show on theglobaldispatch.com. Now, one of the bigger infectious disease stories this past week was the Centers for Disease Control putting out their latest annual sexually transmitted disease surveillance report. And what we found out was more than 2 million cases of chlamydia, gonorrhea, and syphilis were reported in the U.S. in 2016, the highest number ever. And, of course, the majority of these cases were about 1.6 million were chlamydia. And you had nearly 500,000 gonorrhea cases and 28,000 cases of primary and secondary syphilis. Dr. Jonathan Merman, he's the director of the CDC's National Center for HIV and AIDS, Viral Hepatitis, STD, and TB Prevention, said these increases in STDs are a clear warning of a growing threat. STDs are a persistent enemy, growing in number and outpacing our ability to respond. Now, while young women basically bear the greatest burden of chlamydia, the surges in syphilis and gonorrhea are affecting other populations, particularly the men who have sex with men population. And we're seeing large increases of these syphilis cases due to that. But also, there's a 36% increase in rates of syphilis among women, and tragically, a 28% increase in syphilis among newborns. That's better known as congenital syphilis. That's just heartbreaking. More than 600 cases of congenital syphilis was reported last year, which resulted in more than 40 deaths and severe health complications among newborns. Now, the disease is preventable through routine screening and timely treatment for syphilis among pregnant women, so there's not a whole lot of excuse there. The CDC says every baby born with syphilis represents a tragic systems failure. All it takes is a simple STD test and antibiotic therapy to prevent this enormous heartache and to help ensure a healthy start for the next generation of Americans. So you can learn more of that if you go to the website, outbreaknewstoday.com. And there's also a story about, California. Their numbers are through the roof too, so you want to check that out. And I want to thank my guest today, Jeanine Thomas. I want to thank the Miracle Man for keeping things going. And I want to thank you for listening, and I will see you next week on Outbreak News This Week. Good night. God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, OutbreakNewsToday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.